Hello and welcome to part 2 of case files of hemorrhagic shock. We spoke in the first part about the hemorrhagic shock, about the case itself, definitions. We started with the clinical approach, and now we will continue with the clinical approach of hemorrhagic shock. So previously we spoke about the stages of shock: compensated, progressive, irreversible. We spoke of the compensated, and now it is the progressive stage. As the shock evolves into the progressive stage, arterial pressure falls. This leads to cardiac depression from decreased coronary blood flow, and in turn, further decreases arterial pressure. The result is a feedback loop that becomes a vicious cycle towards uncontrolled deterioration. Inadequate blood flow to the nervous system eventually results in complete inactivation of sympathetic stimulation. In the microvasculature, the blood flow causes the blood to sludge, amplifying the inadequate delivery of oxygen to the tissues. This ischemia results in increased microvascular permeability, and large quantities of fluid and protein move from the intravascular space to the extravascular compartment, which exacerbates the already decreased intravascular volume. The systemic inflammatory response syndrome caused by severe injury and shock may progress to multi-organ failure. Pulmonary edema, acute respiratory distress syndrome, poor cardiac contractility, loss of electrolyte and fluid control, and inability to metabolize toxins and waste products set in. Cells lost the ability to maintain electrolyte balance, metabolize glucose, maintain mitochondrial activity, and prevent lysosomal release of hydrolases. So the cells lose this ability. Resuscitation during this progressive state of tissue ischemia can cause reperfusion injury from the burst of oxygen-free radicals. Okay. That was the clinical approach. Now we'll go to the section about pathophysiology and stages of hemorrhagic shock. Hemorrhagic shock is the most common cause of death in trauma patients aside from traumatic brain injury. A high level of suspicion for hemorrhage and hemorrhagic shock should dominate evaluation of trauma patient, especially as vital signs may not become abnormal until a significant amount of hemorrhage has occurred. Hemorrhagic shock is classified by the Advanced Trauma Life Support into 4 categories to further emphasize the progression of vital sign instability in response to blood loss. So there is a small table here, and the classification is according to the amount these things available in the this is the table. You can pause and read. I will just say it in general. So the classification of hemorrhage depends on blood loss, pulse, blood pressure, pulse pressure, respiratory rate, urine output, and central nervous system, the mental status. So the values are available. According to these values, we classified into class 1, 2, 3, and 4 in Latin. Additional clinical signs that indicate hemorrhagic shock include skin pallor and coolness, delayed capillary refill, weak distal pulses, and anxiousness. As demonstrated by the ATLS classification of stages of hemorrhagic shock, the clinician must not rely solely on vital signs for determination of extent of hemorrhage. This patient obviously has had some blood loss from his femur fracture, and the focused abdominal sonography for trauma, FAST, suggests intra-abdominal solid organ injury associated with additional hemorrhage. So, the focused abdominal sonography for trauma, FAST or FAST, the FAST examination suggests intra-abdominal solid organ injury associated with additional hemorrhage. Additionally, This patient's scalp laceration must be evaluated as potential source for serious exsanguination. Despite these multiple sources of hemorrhage, our patient has a normal blood pressure and only a slightly elevated heart rate, which places him in the category of potentially having class 2 hemorrhagic shock, as according to the table mentioned earlier. So, diagnostic approach. Identifying the source of bleeding. A trauma patient should be carefully screened to locate the source of blood loss. In this patient, the possibility of bleeding should be assessed in 5 areas. First, external bleeding. Second, pleural cavity. Third, peritoneal cavity. And fourth, pelvic girdle. Fifth, soft tissue compartments. So, external bleeding such as scalp, extremities, lacerations. Then pleural cavity bleeding such as hemothorax. Then peritoneal cavity bleeding such as bleeding from intra-abdominal injuries. And fourthly, pelvic girdle bleeding such as pelvic fractures. And fifth, soft tissue compartment bleeding such as long bone fractures. Adjunctive studies that should be obtained in blunt trauma patient early during their evaluation include chest and pelvic X-ray and CT scans of the head, abdomen, and pelvis. Chest X-ray can identify a hemothorax and potential mediastinal bleeding. Pelvic films can demonstrate pelvic fractures as a source of pelvic blood loss. And films of any affected extremity, in this case his femur, should obviously also be obtained. Fractures are not only associated with blood loss from the bone and adjacent soft tissue, but their presence indicates significant injury transfer and should increase the clinical suspicion for intra-abdominal and retroperitoneal bleeding. Typically, tibial or humeral fractures can be associated with 750 milliliters of blood loss, 1.5 units of blood, whereas femur fractures can be associated with up to 1,500 milliliters of blood, which equals 3 units of blood. In the thigh, pelvic fractures may result in even more blood loss, up to several liters can be lost into a retroperitoneal hematoma. Laboratory evaluation. Laboratory studies that aid but are not very useful in evaluating acute blood loss are hemoglobin, hematocrit, base deficit, and lactate levels. In the setting of acute hemorrhage, hemoglobin and hematocrit levels may or may not be decreased. These values measure concentration, not absolute amounts. Hemoglobin is measured in grams of red blood cells per deciliter of blood. Hemoglobin is measured in grams of red blood cells per deciliter of blood. Hematocrit is the percentage of blood volume that is red blood cells. Loss of whole blood will not decrease the red blood cell concentration or the percentage of red cells in the blood. The initial minor drops in hemoglobin and hematocrit levels are the results of mechanisms that compensate for blood loss by drawing fluid into the vascular space. To see a significant decrease in these values, blood loss must be replaced with crystalloid solution. Therefore, most decreases in hemoglobin and hematocrit values are not seen until patients have received large volumes of crystalloid fluid for resuscitation. With the ongoing metabolic acidosis of hemorrhagic shock, an increased base deficit and lactate level will be seen. Both lactate and base deficit levels are laboratory values that indicate systemic acidosis, but not local tissue ischemia. They are global indices of tissue perfusion, and normal values may mask areas of underperfusion as a consequence of normal blood flow to the remainder of the body. These laboratory tests are not true representations of tissue hypoxia. It is therefore not surprising that lactate and base deficit are poor prognostic indicators of survival in patients with shock. Although absolute values of these laboratory results are not predictors of survival in patients with shock, the baseline value and trends can be used to determine the extent of tissue hypoxia and adequacy of resuscitation. Normalization of base deficit and serum lactate within 24 hours after resuscitation is a good prognostic indicator of survival. Of note, given that lactate is hepatically metabolized, it is not a reliable value. It is not a reliable value in patients with liver dysfunction. Thank you very much for listening to part 2. And now, inshallah, we'll go to part 3 and continue by talking about the central monitoring in such patients. Thank you very much for listening, and please stay tuned for part 3.